Hello, I'd like to welcome everyone back to EMS Monthly Education for the July 2023. I hope everyone is doing well. This month we will be focusing on trauma. Our topic of discussion will be hemorrhage control and fluid resuscitation for the first hour. The objectives that we will cover, we'll talk about identifying and treating severe hemorrhaging. We'll talk about tourniquets, junctional tourniquets, hemostatic agents, along with TXA. We'll also discuss permissive hypotension, the research behind it, and arterial pressure as a tool to evaluate perfusion. All right, so we'll start out with basic anatomy and physiology. This month we'll be talking about the circulatory system or the cardiovascular system. And as we know, the circulatory system consists of several different components. We've got the heart, we've got the vascular system, and we've got the blood. The overall function or the overall responsibility of the circulatory system is to circulate blood to and from the heart. We've got our arteries, which carry blood away from the heart, and then we've got our veins, which carry blood back to or bring blood back to the heart. The circulatory system is also responsible for carrying oxygen and nutrients to the cell and also removing waste products or CO2 from the body. This is what's called perfusion. This is how perfusion actually occurs. All three of those components, the heart, the blood vessels, and the blood, all three components have to be in working order in order for perfusion to occur. If not, we have to deal with an issue that's called shock or inadequate tissue perfusion. And once again, the cause of shock or inadequate tissue perfusion is one of these three components failing. The heart becomes ineffective as a pump. The blood vessel basically loses its vascular tone and starts to overdilate. And then when it comes to blood, there's too much blood that's lost or also fluid loss. And this is going to be secondary to trauma patients. One of the things that I want you to remember as a provider, basically everything revolves around shock. Either respiratory distress that's not taken care of, and then shock. Shock is going to be one of the number one or the number one killer when it comes to trauma patients, dealing with these trauma patients. Now, the most common cause of shock when it comes to trauma patients is going to be blood loss. One of the things that we have to remember about one of the components of blood, which are your red blood cells, these red blood cells carry oxygen all over the body. Red blood cells, they also remove carbon dioxide from the body. The red blood cells bring the carbon dioxide into the lungs and the person exhales, removing that carbon dioxide from the body. When it comes to patients suffering from these traumatic injuries and they are bleeding, you notice that gross or heavy external bleeding. One of the things as providers that we want to do is make sure that we stop that bleed. Every red blood cell counts. Every red blood cell counts. So that's going to be very important that we stop the bleed as soon as possible. Hemostasis. Hemostasis is the opposite of bleeding. This is how the body naturally stops to bleed on its own. Now, the body is very fabulous. And one of the things is it's going to take care of itself. That traumatic experience happens. Once again, that traumatic experience happens. The body recognizes, hey, there is a problem, and the body attempts to correct this problem by naturally attempting to stop the bleed on its own. There is a three step process. The first step is vasoconstriction, and this allows less blood to be lost from the body. Then the second step is the platelet formation. In the platelet formation, the platelets basically stick together to perform a plug. And then this is the break in the blood vessel. And then the body releases what's called the fibrin. This is going to be the coagulation phase. The body releases this fibrin, and this fibrin acts like a glue to make the clot or that plug a lot stronger. Now, just like anything else, there are factors that come into play when it comes to the body naturally stopping the bleeding itself. When it comes to fractures, movement of the wounds at the site, these fractures, you've got those bone ends that's moving. This is why it's so important. After you perform that primary assessment, you move into your rapid trauma assessment and you try to identify whether there's a femur fracture, whether there is a pelvic fracture, and we want to splint these areas as soon as possible. With the femur fracture, you can lose up to 1,500 milliliters of blood. With the pelvic fracture, you can lose up to 2,000 milliliters of blood. Another factor that we have to consider is aggressive fluid therapy. With that aggressive fluid therapy years ago, when I finished medic school, we were all taught, hey, two large bore IVs running up wide open. All that excess fluid does is dilute that natural clot and eventually pops that natural clot that the body has formed. A third factor to consider here is low body temperature. It does not matter where you are. You could be at the tip of Texas, you could be at the tip of Florida, you can be in Minnesota, you can be in North Dakota. Shock is shock. And when these patients start experience that inadequate tissue perfusion or shock, guess what? This affects and this slows that natural clotting cascade. So one of the things that we want to do as providers is make sure, once you get that patient naked, once you get that patient trauma naked, that you're keeping that patient warm as well. Covering them with the blanket, turning the heat up in the back of the truck. This is one of the reasons that if you've ever gone into a level one trauma center or these level trauma centers and walk into these trauma bays, you literally walk out sweating because it's so warm in there. Then one of the most important ones, or very important ones, are the different medications that these patients may be taking. Some of these medications are used to prevent strokes. They're used to prevent MIs, and the job is to prevent clotting. This puts these patients at an increased risk of bleeding. It can worsen the bleed, and we're looking at medications like aspirin, uh, looking at medications like Coumadin, Lovenox, Plavix, Brilinta. Once again, these medications worsens bleeding. Some other medications to consider are your beta blockers, and with these beta blockers, these are medications that end in OL. Metoprolol, atenolol are two of them that come to mind. What they do is they mask that tachycardia that comes along with the blood loss, and sometimes it can mask the diaphoreses. When it comes to these signs and symptoms, it may make it difficult. So, knowing this about these medications, making sure that you perform a thorough interview on these patients and get all of this information as soon as possible is going to be very, very important when it comes to dealing with these trauma patients. All right, so our dispatch information for this evening, we're going to be dispatched to a stabbing. We're going to be dispatched to a stabbing. We have received our dispatch information. We know that we are being dispatched to a stabbing. PD is on scene, states that the scene is safe. As we approach our patient, our general impression of our patient is this. We've got heavy bleeding coming from that left groin as we approach our patient. One of the first things that we want to do is make sure that we start by cutting this patient off so we can actually set eyes on this injury. And what we're looking at here, this is going to be a pretty deep wound, and we've got some gross bleeding. So one of the first things that we want to do, typically we would go airway, breathing, circulation, but we are trying to identify life threats, and this appears to be a major life threat here. One of the first things that we want to try to do is start by trying to stop this bleed as soon as possible. Another thing that we need to consider here, this is going to be an area that is not tourniquet friendly. This is going to be what's called a junctional area. So what we're going to do is immediately start by providing direct pressure to stop the bleed. Not only direct pressure, we're going to, and we'll talk about it a little bit more, about wound packing. So this is going to be very, very important that we stop the bleed. Once again, every red blood cell counts. The red blood cells are going to carry oxygen throughout the body. Not only are they going to carry oxygen throughout the body, but they're going to remove waste products as well. So every red blood cell counts here, and making sure that we make the attempt to stop the bleed as soon as possible. So we identify that we're dealing with a 40-ish-year-old male. He's found lying supine on the ground, heavily bleeding from his left groin. This is going to be our life threat. We make that attempt to stop the bleeding as soon as possible. That's the first thing that we're going to do. His airway appears to be patent. He is tachypnic. We listen to breath sounds. His breath sounds are clear bilaterally. Checking circulation, he has a weak radial pulse. His skin is pale, ashen, and diaphoretic. So as a provider, one of the first things that I want to do is make sure that I place this patient in a category. And this patient is going to be unstable. And the reason that he is unstable, this uncontrolled bleeding, this heavy bleeding from that left groin area, from that junctional area that is not tourniquet friendly. This is an area that is not tourniquet friendly. So our next option is to provide that direct pressure along with wound packing. We noted that he is tachypnic, no abnormal breath sounds, but he's telling us a story. Once we get to circulation, we are evaluating that person's circulatory system. And we've identified that this patient has weak radial pulses, that his skin color is definitely off, which isn't norm. So he's telling us a story. He's telling us, or telling me right now, that he is in bad shape. So this patient is unstable. And not only is he unstable, thinking ahead, this is going to be a level trauma. This is going to be a level trauma. So the first thing that I want to do as far as emergent treatment is, being that he is perfusing poorly, I want to place this patient on high flow O2 via non-rebreather 15 liters per minute and start treating this patient for shock along with stopping that bleed. This is going to be very important. One of the things as providers that we have to remember when it comes to blood loss, a person can bleed out within 3 to 5 minutes. The average time for first responders is going to be 7 to 10 minutes. So something to think about here. Going back to that junctional area that we're dealing with, in situations like this, with wounds like this, we have to keep or have that high index of suspicion. We have to have that high index of suspicion. This is going to be very difficult. This is not just going to require a little direct pressure, but this particular area, this growing area, is going to require quite a bit of pressure to actually stop that bleed, because within this growing area, guess what? We are dealing with large vessels, and these large vessels, especially these arterial vessels, are under pressure. They're going to be under pressure. These are going to be your arteries that are going to be under pressure. Not only are your arteries large in this particular areas, but your veins are large as well. And then we also have to think about the possibility of nerve damage as well. All right, so we've got our different treatment zones when it comes to stopping bleeding. We've got the pinkish color. These are areas that are non-tourniquet friendly. They are not tourniquet friendly. So with these particular areas, what we want to do is provide that direct pressure along with wound packing as well to stop the bleed. If we look at the areas that are blue, this is going to be the area of the chest, or what they call the box. And this is an area where we are going to use seals. And then if you look at the green, these are your tourniquet friendly areas. Your extremities, upper extremities, and also your lower extremities. Now, when it comes to wound packing, you're not just dealing or trying to provide that direct pressure. If you notice his fingers, he's actually, or she's actually packing that wound with 4x4s or whatever roller gauze that you have to use for packing to actually stop that bleed. Once again, when it comes down to direct pressure, if it comes down to external bleeding, this is one of the things that we're going to use in conjunction with direct pressure, is the actual wound packing itself. Now, we try to get as much information as we can. Number one, and the reason we try to get as much information as we can is because we're dealing with a level trauma. This patient is losing a lot of blood, and there's a possibility that, guess what, this person's mental status is going to start dropping. So we know that we've got a stab wound to the left groin. He's not allergic to any medicine. He takes metoprolol along with aspirin for his meds. His past history is hypertension and stroke. His last oral intake was 2 hours ago. Events leading up to it, he got into an argument with a friend and he was stabbed in the groin area. This was a sudden onset. Things that make it worse is movement. The pain does not radiate. Right now, he states that it's a 5 on a scale of 0 to 10. And then this all happened about 10 minutes ago. My concern with this interview process is the medication that he's on. Number one, he's on aspirin. So this tells me that there's a possibility that his bleeding could be worsened due to the aspirin, but the metoprolol, which is that beta blocker that we talked about, this could possibly mask the signs and symptoms of shock that that patient may be having. But at this point, what we've seen from, or what I've seen from the primary assessment, he is tachycardic and he is diaphoretic. But once again, as a reminder, these are medications. Number one, aspirin could worsen the bleed. And then number two, that beta blocker could mask those signs and symptoms. So just something to think about here. All right, so we quickly move into our secondary assessment, which is our head to toe trauma assessment, our rapid physical exam. And when we are performing our primary assessment, our overall goal of our primary assessment is to identify those life threats and manage those life threats as we go. Now, when it comes to our rapid assessment, rapid trauma assessment, the overall goal is to identify any hidden injuries. That rapid trauma assessment should not take no more than 60 to 90 seconds to actually perform. So we assess the head. His head is unremarkable. His face is unremarkable. We note that there is a mental status change. We're now noting that confusion is coming into play. If you do not get anything else out of this, please understand that that patient's mental status, when it comes to trauma, is going to be your number one indicator of perfusion. This is going to be your number one indicator of perfusion once you start noticing those mental status changes. We move down to his neck. His neck is unremarkable. His chest, he's got clear breath sounds bilaterally. His abdomen is soft, non-tender. His pelvic area, we noted that there is approximately 2-inch penetrating wound to his left groin with major bleeding. We are attempting to control the bleeding via packing and direct pressure. And this is going to be constantly held throughout transport as well. Lower extremities, unremarkable. We've got weak distal pulses bilaterally. We log roll the patient as a unit, check his back, and his back is unremarkable. So my biggest concerns here in our trauma assessment is going to be his mental status. His mental status is starting to drop. We're dealing with an altered mental status. He was awake and alert, able to give us all of our pertinent information when it came to the interview. And now we're noticing that there is a mental status change, which is going to be indicative that his perfusion is getting worse. His overall perfusion is getting worse. Another concern here is going to be those distal pulses, those weak distal pulses. This also signifies that perfusion is getting worse. The body is making an attempt to actually take care of itself by shunning the blood from the periphery or from the surface to the core to take care of those vital organs. All right, so when it comes to bleeding, we've got two different types of bleeds that we actually are able to identify. We've got external bleeding that we can see and we can hopefully control. With our external bleeding, once again, we can see this blood loss, direct pressure along with wound packing, depending on the type of the wound, remains number one. So direct pressure, if the bleeding does not stop when it comes to using direct pressure, we move into our tourniquets. Our indications for a tourniquet, external bleeding that can't be stopped or can't be controlled by direct pressure. And in some instances, we have to use more than one tourniquet. When it comes to the effects, if that tourniquet is correctly applied, you should see an absence of a distal pulse. So that distal pulse, if that tourniquet is applied, you're going to lose that distal pulse. Not only losing that distal pulse, but if that patient is awake and alert enough, that patient may or will be, this will be very painful for that patient as well. Contraindications. When it comes down to tourniquets, there are no emergency situations. There are none in emergency situations. So there are no contraindications. Once again, it's been proven to work. Evidence-based medicine. The research has been done and it's been proven to work. This is a tool that when I graduated medic school in 93, Tourniquets were last resort. They were last resort. Now they're at the front of the line. Now they are at the front of the line when it comes to tourniquets. Our junctional tourniquets, which we spoke about, these are areas that are non-tourniquet friendly, not tourniquet friendly, and you're going to have a hard time attempting to get a tourniquet in place. We've got our neck, we've got our axilla, and then you've got those groin areas. We have, or there are, um, tourniquets that are available, junctional tourniquets that are available that can be used. The first is going to be your SAM junctional tourniquet. And with your SAM junctional tourniquet, this particular tourniquet is designed to control bleeding. It can be used in the axilla area and also the groin area. And also it can be used to secure a pelvic fracture as well. If you look here, this looks like or this is the same as your old manual blood pressure cuffs. And so it has that pneumatic concept that's used. And this actual device we think these are going to be your landmarks here. Once that you pump it up, the idea is to place as much pressure on those large vessels to actually stop the bleed. Another junctional device that's used is going to be the abdominal aortic tourniquet. This has been around for several years now, used by the military as well. These are approved by TCCC to be used in the not only the military setting, but in the civilian setting. This is one, the SAM junctional, that we use when we're training in PHTLS and also TCCC courses. Once again, the abdominal aortic tourniquet, it's designed to stop bleeding as well, and it can be used in those junctional areas. The axilla area, also the neck as well. It can be used for pelvic fractures, and it has that whole pneumatic concept as well. There are a number of different YouTube videos out there with this particular junctional tourniquet. And it can be applied within anywhere from like 30 to 45 seconds or so. Uh, we've got our hemostatic agents, or our topical hemostatic agents, that are still popular. They are popular, especially when it comes to lay people, or they're using them in their first aid kits. They come in the form of powders, granulas, and then you've got your impregnated dressings as well. And they are applied directly to the wound to stop the bleed. The recommendation is to use it according to your manufacturer's directions. Another hemostatic device, or a hemostatic agent that's used to control bleeding, is called the XStat. And XStat has been approved by the FDA to be used in the civilian setting. The military has been using this for some time, but it's used for penetrating wounds when it comes to those junctional areas. You've got a 35 millimeter syringe that's filled with small compressed sponges. Once those sponges are expelled from that syringe and they come in contact with the body fluid or the blood, they basically expand and they create a temporary blockage to control bleeding. Then our second type of bleeding that we come in contact is going to be our internal bleeding, or internal hemorrhaging. And this is going to be bleeding that we can't see. The signs and symptoms, or the signs, may be limited only to signs and symptoms of shock. So it is very important as a provider that you're able to identify these signs and symptoms in your primary assessment. Once again, as a reminder, shock is going to be your number one killer when it comes to these trauma patients. Another thing that we want to remember when it comes to significant mechanisms of injury, always keep a high index of suspicion, especially if you've got trauma that's been applied to the chest, the abdomen, and the pelvic area. These are areas where your large vessels, all of your your major internal organs are located. So once again, always keep a high index of suspicion when it comes to these areas. One of the things I always say, looking at this bruise here, this looks really, really bad. But if you think deeper, keeping that high index of suspicion, if it looks that bad on the outside, what do you think's going on the inside? What do you think is going on the inside? Other things or other areas that we want to pay attention to are your orifices, the nostrils, the ears, the anal area or the anus and the genitalia area. If you and what you're looking for is blood loss from these areas. This may signify that this patient is suffering from internal bleeding. You can see from these numbers here, the blood loss from internal bleeding, the humerus, tib, fib, those long bones. A person can lose anywhere from 500 to 750 milliliters of blood. You're looking at your femur fractures up to 1500 milliliters, pelvic up to 2000, and then just large contusions up to 500 milliliters of blood can be lost when it comes to these patients. Another junctional tourniquet that's used quite often for pelvic fractures is going to be your sound pelvic splint. It's gained a lot of popularity within the pre-hospital setting as well. Once again, as providers, we arrive on scene with these patients. We want to try to find this pelvic fracture after we've performed a our primary assessment. We move to our rapid trauma assessment, which should take no more than 60 to 90 seconds. Once again, the overall goal of the rapid is to identify those hidden injuries like your pelvic, like your femur fractures. And these are the fractures that we want to make sure that are splinted before we transport. And the reason is if we've got those bone ends that are moving during transport, this goes back to hemostasis, that natural clotting. All you have are those bone ends that are moving around, disrupting that natural clot that has been uh, formed already by the body. Then we have TXA. TXA is a medication that's been around for some time, but here within probably the past 10, almost 15 years, been used more and more in the pre-hospital setting, and it's used to control bleeding. It does not stop the bleeding. But what it does is going back to hemostasis, that three-step process of the body attempting to naturally stop bleeding. You have the vasoconstriction phase, which slows the bleeding. You have the platelet formation, and then the body releases the fibrin to actually strengthen the clot. Once the TXA is administered into the body, the TXA prevents the fibrin from breaking down. So it's actually going to go in and strengthen that clot once it's introduced into the body. And typically, your dosage or setup for this is going to be a gram into a 100 milliliter bag of normal saline, and it's ran over 10 minutes. Another thing that we have to think about here, we have to ask ourselves, does this patient meet the criteria to be spinal immobilized? Now, it was a stabbing, and 9 times out of 10, this patient does not. This is one patient you don't have to spinal immobilize, but it will be easier to move this patient. You can place a C collar on this patient, but with the long backboard, it will be easier to move the body from the ground to, or the not the body, but the patient from the ground to the stretcher, or to the stretcher, uh, um, to the hospital bed as well, or if this is an intercept from stretcher to stretcher. But as far as spinal immobilizing, the altered mental status, yes, he meets the criteria due to the altered mental status, but this isn't a patient that necessarily needs to be spinal immobilized. GCS, when it comes to GCS, this is going to be very important information to relay during your intercept, if this is an intercept or transfer of care once you arrive at the receiving facility. Our patient initially has the GCS of 15. Initially had a GCS of 15, but during our rapid trauma assessment, we noticed that his mental status started to decline to from awakened alert to confusion. And so what we're looking at now is a GCS of 14. And one of the things that we want to do when passing this information on is to make sure that we have a definitive number, not an approximation. One of the things that I used to hear listening to radio reports is medics calling in GCX. We've got a GCS of approximately 13 or 14. Don't give an approximation. It's simply doing your job, being a competent provider, and giving a definitive number, making sure that you reassess their GCS throughout transport, documenting their GCS, and passing this information on during your intercept, if this is an intercept, or once you transfer care over to the emergency department staff. Now, we found out or figured out in our primary assessment that this patient was unstable. Not only did we categorize this patient as unstable, but this patient meets the criteria to be transported to either a level 1 or level 2 trauma center. Once again, this is important information that needs to be passed on, especially if we are in rural areas and dealing with our non trauma leveling hospital. This is critical information that could be passed on during your pre-alert. You know, they can at least have the helicopter on the way, or have teams there. If they have to call in extra personnel, they can have those extra people called in to assist, so that that person can be transported to that level 1 or level 2 trauma center. Now, evidence-based medicine, best practices, guess what? It has been proven to work. It has been proven to work. And these are things that we have to do or need to think about doing when we're dealing with these level traumas. When it comes down to systems of care, you've got your big four. You've got acute MI, you've got stroke, you've got your level trauma, and recently added were septic patients. We're dealing with trauma this month. So guess what? We're dealing with a level trauma. Some of the things that you have to think about: scene management, trying to make sure that you're off scene within 10 minutes. This is the national time here, within 10 minutes. This is what's called the platinum 10 when it comes to the golden hour or the golden period. As providers, we have that 10-minute on scene time. Now, You don't have to break your neck. You don't have to start sweating. You don't have to get in a big rush to where you are injuring yourself or someone becoming injured. Guess what? Having that sense of urgency, having a game plan, knowing how to move. Not all of these level traumas are, especially when it comes to extrication or moving that patient from a second or third story building, are you going to get off scene within 10 minutes? Simply make sure that you document the reason there was a delay. It may be a 2-minute delay, 1-minute delay, up to 4 to 5 minute delays, but make sure that you document the reason, especially if you are running with those systems that actually, those modeled systems that actually pay attention to all of that when it comes to documentation. Another thing that we need to do, going out doing simulation at a lot of these hospitals. This is one of the biggest complaints that we hear. EMS providers not communicating with the hospital. Providing that trauma alert is going to be critical. It does not have to be a long, drawn out radio report. All you need are your basics. What you found in your primary assessment, let them know that you're going to give them an update report en route, but let them know that this patient meets the leveling criteria. That this patient meets the leveling criteria. Then there's the GCS. We talked about the GCS. One of the things that we want to do or we have to do is provide this information, and we want to provide, as competent providers, we want to provide a definitive number and none of the approximations. These are going to be patients that need to be transported to that level trauma center. And so providing that pre-alert, hopefully the hospital staff is actually listening to you, paying attention to you, trusting you, and especially in these rural areas, and getting air ambulance en route to get that patient to that level 1 or level 2 trauma center. All right, so we identified that this patient meets the leveling criteria. We talked about systems of care. This brings us to our golden hour. Our golden hour has been changed to the golden period. Initially, the golden hour, it said that if that patient experiences this traumatic event, if that patient can, from the onset of the traumatic event, could be with the trauma surgeon in definitive care within an hour, that patient has a better chance of survival. And once again, that 10-minute on scene time that we just talked about, that's the platinum 10 within that golden hour. That's the platinum 10. Here recently, PHTLS changed it from the golden hour because initially it was for urban areas. But recently, it was changed from the golden hour to the golden period to include rural and frontier medicine as well. Once again, I can't say enough about communicating with the hospital. We have to provide these trauma alerts to the hospitals so that they can prepare. They can prepare their trauma teams. So communication is going to be very, very important here. Very important. So we've packaged our patient. We're preparing for a transport. We met our on scene time within 10 minutes. One of the first things that we're going to do is obtain our baseline vital signs. He is tachycardic at 123. For some reason, we can't get a SpO2 reading. He is tachypnic at 30 breaths per minute with an end tidal of 28. We've got a mean arterial pressure of 62 and a blood pressure of 82 over 52. Concerning? Yes, very concerning. This guy is tachycardic at 123. our O2 sat will not pick up. And for those that are dependent on that O2 saturation, guess what? With trauma patients in this stage, this is what you're going to see. This is what you're going to see. This is one of the reasons, don't be so dependent on those O2 saturations. Your assessment, paying attention to your patient, is going to tell you basically just about everything that you need to know. And the reason that he's not picking up is because he is perfusing very badly. This is poor or inadequate tissue perfusion that we're dealing with. He is tachypnic, so we've got low end tidal readings. Looking at this blood pressure, 82 over 52, his blood pressure's dropped. So he's moved from compensating to a stage of decompensating with that low blood pressure, and the next stage is going to be irreversible. So this guy is sick. This is inadequate tissue perfusion all day, every day. All day, every day. But then this mean arterial pressure, which is a vital sign that's rarely used in the pre-hospital setting, other than when you are dealing with flight medics, flight nurses. But then you go in the hospital, this is more valuable than this calculation here. And we're going to talk about that in a few minutes here. That mean arterial pressure map of 62. This basically tells me, just looking at this number, that this guy is sick. This guy is sick. His vital organs are not being perfused properly. So we obtain a blood glucose level. Even though that we're dealing with trauma, we're going through our differential diagnosis, trying to figure out why this patient is altered. He's moved from an awake alert mental status to an altered mental status with the confusion. So we obtain the blood glucose reading. We get a blood glucose reading of 100. We get a temperature of 97.8. Once again, with shock. It doesn't matter if you're at the tip of Texas or if you are in Minnesota or North Dakota. Shock is shock. And guess what? Their body temperatures are going to start dropping. This affects that natural. Once again, it affects that natural cascade when it comes to the natural way the body stops the bleeding. So just like we've got them trauma naked, we need to start trauma warming them so that person, this patient, does not lose too much body heat. Um, we need to start thinking about fluid. We have to start thinking about fluid. This term, permissive hypotension, aka damage control resuscitation. We want to avoid giving this patient too much fluid, because all we're going to do is dilute the blood and eventually pop that clot. And that's what we want to avoid, popping that natural clot. Now, when it comes to this IV fluid, normal saline lactated ringers, guess what it does not have? It doesn't have red blood cells to carry oxygen, and it doesn't have oxygen in it. It doesn't have red blood cells or oxygen at all. Now, when do we actually need to give fluid? If that patient has a systolic blood pressure that's greater than 90 and a heart rate that's less than 120, guess what? If you do start a line, just run it at TKO. If you start a saline lock, that's cool. But these are patients that don't need fluid. The patients that need fluids, you got a systolic blood pressure that's less than 90, and you got a heart rate that's greater than 120. These are going to be your patients that need fluid. And we can start our fluid boluses. It's your preference, 250 bolus up to 500 milliliter boluses. Once you start getting at that 2 liter or has given a total amount of 2 liters, especially if they're in the hospital, guess what? They're going to start thinking about blood products. They're going to move into that massive transfusion protocol. Once again, this goes back to communication. You in the hospital, you in the hospital communicating, because the sooner you can relay this information, the sooner they can have their team in place. And guess what? Those blood products can be on their way. Those products can be on their way. Now, your boluses, 500, 250 milliliter boluses, we're going to check radial pulses. You are doing your job. If you start bolusing this patient and you notice that those radial pulses start getting stronger, that patient's mental status start to improve, guess what? You are doing your job. The overall goal of uh, uh, this permissive hypotension in these boluses is to start perfusing those vital organs. Once again, your number one indicator when it comes to perfusion is going to be that patient's level of consciousness. It's going to be that patient's level of consciousness. You're going to see the changes when it comes to their mental status. From awake and alert, you're going to see anxiety, you're going to see confusion, and then also combativeness. This is all going to be indicators of poor perfusion. All indicators of poor perfusion. But things that we want to avoid is that aggressive fluid therapy. It is not recommended because all it's going to do is pop that natural clot. It's always better to maintain than increase. Once again, the dangers of too much fluid is you're diluting the blood, you're popping that natural clot. And one of the things that we have to remember that I mentioned earlier when it comes to that normal saline, the lactated ringers, there's no red blood cells in it. There's no oxygen in it. So these are things that we have to think about. So we start our bolus process with the patient. We now notice the heart rate has come down to about 120, kind of holding steady. Our O2 sats picking up. We've got them on 15 liters per minute, and we're now at 93%. He's still tachypnic. End tidal is still a little low. Our blood pressure has started to improve. 94/60 now, with a mean arterial pressure of 71. Now, when it comes to that map, that mean arterial pressure. Looking at all of these numbers, they're slowly starting to improve. Your heart rate is decreased from the 130s to the 120s. He's picking up the O2 sat's picking up. He's 93%. His blood pressure is starting to improve. It's come up several points to 94 systolic. And his MAP, that mean arterial pressure, was initially in the low 60s or so, and now it's starting to improve to 70. When it comes to that MAP, or that mean arterial pressure, this is a vital sign that is ignored in the pre-hospital setting. Once again, uh, uh, your flight medics, not only your flight medics, your flight nurses use it. But in the pre-hospital setting, if you go into a hospital in the emergency room setting, not only in the emergency room setting, just anywhere in the hospital, that's the first thing that they're going to be looking at is that map, that patient's map. They're going to be looking at that. This is once again one of the most ignored vital sign that's out there, but it's the best way to monitor overall perfusion. It's the best way to monitor overall perfusion. The range that you're looking at a range or in between 70 and 110. 70 to 110. Anything below 70, guess what? You're dealing with perfusion issues, shock, sepsis, internal bleeding. Anything greater than 110, you're looking at increased pressure in the arteries, acute MI, heart failure, kidney failure, or something like that. What we want to do in the field, especially if we're providing fluid therapy, is to aim. Instead of when we're bolusing these patients, we're thinking about permissive hypotension, better to maintain than increase. Guess what? If we can keep that map between 60 to 65 during fluid therapy, guess what? Those vital organs are being perfused. Those vital organs are being perfused. All right, so you continue monitoring your patient en route to the emergency department. After reassessing, you call your radio report, give your ETA. The patient is delivered to the emergency department. You give a verbal report to the attending physician and return back into service. Educational pearls to consider here. Tourniquets may be placed initially to stop bleeding. You may have to use multiple tourniquets. We don't want to remove that tourniquet once it has been in place. If the tourniquet is replaced with a pressure dressing, leave the loose tourniquet in place so it can be retightened if bleeding resumes. Utilize your hemostatic agents or gauze if it's available. If it's not available, you can still use your 4x4s, 5x9s, your different trauma dressings that you would normally use for these patients. In the past, we would use pressure points, but pressure points pressure points aren't used anymore. They're not effective when it comes to controlling the bleeding. Amputated parts should be transported with the patient for reimplantation. We want to make sure that the amputated part is placed in a plastic bag, then place it on ice in a second plastic bag. Don't let that amputated part come in direct contact with the ice. When it comes to quality improvement and documentation, things that we want to document, their vital signs, their vascular status after the splint has been applied or the tourniquet has been applied, even the pressure dressing as well. We want to document that you lost distal pulses once that tourniquet was placed and the time that that tourniquet was placed as well. Performance measures that we want to meet as providers, not only as providers, but as in service as well. Making sure that that tourniquet was placed properly, that that distal pulse was lost, making sure that you mark the time on that tourniquet, and making sure that splints were applied to fractures as well. This concludes the first topic for the month of July 2023.